Thank you, Dr. Jawad. We are going to talk about the problem of non-alcoholic fatty liver disease. First, I'm happy here to welcome you to our conference. I'm happy to be with my colleagues here, our guests from outside Bahrain and from the Gulf region. Thank you very much for coming. Okay, so first of all, I would like to give this to the soul of in memory of our beloved colleague, Professor Hisham Izzat. We lost him like these days last year. So may his soul rest in peace. Okay, what is our agenda today? We are going to know what is Nafld or non-alcoholic fatty liver disease, the prevalence regional and internationally, the clinical importance, and who's should be evaluated, who's at risk, and if we have any new potential of treatment. First, some terminology that could be missed from some of us. Alcoholic liver disease, we use this term when we have significant liver alcohol. And what is significant liver alcohol? Actually, this is the consensus of having more than 3 drinks per day for men and 2 only for women. And what is the drink defined? Recent consensus or the alcohol equivalent, it's a drink with 14 gram pure alcohol. Nafld is non-alcoholic fatty liver disease is simply steatosis or fat content inside the hepatocyte without injury. When we have inflammation or hepatocyte injury, it's called NASH or non-alcoholic steatohepatitis. Is a clinical pathological syndrome ranged from simple steatosis to non-alcoholic steatohepatitis with varying amounts of fibrosis and cirrhosis, as we mentioned. And to define this, we have first to get evidence simply by imaging or histopathology, and then in the absence of secondary causes, mostly like alcohol, viral hepatitis, and some medications. This is actually a nice illustration. I'm not sure. Okay, here we can see the normal liver macroscopically and the yellowish greasy enlarged liver with fat content. And here is under the histopathology, and this is the signature appearance under microscope because of the presence of fat globules. So our colleagues of histopathology usually like to classify the non-alcoholic fatty liver disease or the fat content within the liver into microvesicular or macrovesicular. And what we are interested as internists are the causes of this. So commonly microvesicular with hepatitis C and alcoholic liver disease, while the macrovesicular, according to the size of fat globules, is usually with medications. So we come to the point of prevalence. It's globally about 25% with a wide range in the Western countries from 17 to 46. And what is interesting that we have the highest rate here in the Middle East with 32%, maybe less in Africa and Asia, but it's insidious in Asia because we get Nafld with lower body mass index as usually in the other parts of the world. Most of the patients, of course, have diabetes, and up to 80% they have insulin resistance. So the 25% prevalence of steatosis could progress to NASH in 3 to 5%, and then cirrhosis up to 1 to 2%. What is the problem in our region? We have a large study, was done in Saudi Arabia and Emirates, and it was an estimation to have all age estimation of non-alcoholic fatty liver disease to be 24.8 in Saudi Arabia and comparable number in Emirates. But that was estimation in relation to the increasing prevalence or incidence, of body mass index. In a recent nice cohort in Egypt done with Professor Hamdi from Joslin Institute in Harvard, they screened a batch of students with new admission to a private university, and they found 1 in every 3 have steatosis or Nafld, and 1 in 20 they have advanced fibrosis, and this is one of the problems of this Nafld. So to summarize this progression from fatty liver to steatohepatitis, and then with injury and inflammation to fibrosis and cirrhosis, and finally what we used to call the cryptogenic cirrhosis. Actually, maybe we have now more clear picture about the cause of this cryptogenic cirrhosis. What other clinical uncovered aspect of this Nafld problem? NASH actually related to HCC, and those who are going to perform transplantation for HCC, NASH is the second leading cause of that. And what is insidious in this patient, 40% of NASH-related HCC had no evidence of cirrhosis. This is much more than the hepatitis-related transplantation. Also, relation to cardiovascular event, which is another aspect of the problem we have. Nafld actually is considered as the hepatic manifestations of metabolic syndrome. This is usually what we hear from our cardiology colleagues when they describe the Nafld, and it's associated definitely with increased risk of fatal and non-fatal cardiovascular events. So how could we diagnose as internists? What should we know simply in our daily practice? This is the non-invasive methods as abdominal ultrasound. Not good with using. Okay, here we have the echogenicity of the liver in abdominal ultrasound. Usually we compare the echogenicity with the renal parenchyma. So here, this is isoechoic liver, the normal, but on the right side, we have the hyperechoic liver. So we see hyperechogenicity compared to the renal parenchyma. If we shift to the CT, another method of evaluation. We compare the density, we call it density in CT, not echogenicity, but we compare the liver density with spleen. So in fatty liver, the liver is hypodense in relation to spleen. This is some practical point to know as family practitioner or general internist, how to initial evaluate or screen for fatty liver and how can we further refer. Recently, we have the technology of FibroScan. I'm not going in details of FibroScan, but what we need to know is that the advantage of FibroScan is mainly that they can quantitatively detect the level of fibrosis within the liver. On the other hand, what is very important to us and spare a lot of effort, money, and patient injuries or side effects is it can spare a lot of liver biopsy, because by FibroScan we have a cutoff value that can exclude significant liver fibrosis, which is one of our main clinical importance or problem with Nafld. So how is this technology helpful and available? In one of our groups, research we did 3 years ago in Würzburg, Germany, we had some interesting findings. First of all, what most of all of us know, the results that we had Nafld in association with the usual risk factors. More than 70%, they had body mass index above 30, about 60%, they had type 2 diabetes, which is a major risk factor, warrant follow-up and evaluation, hypertension in more than 65, and dyslipidemia in half of the patient. The overall prevalence in our cohort was actually only 20% for those who are visiting the outpatient clinic in our center. Over 1 year, we did that. What is interesting that can show us the magnitude of the problem is not really uncovered. Who diagnosed this problem for the first time? We classified our category into 2 patients, mainly those who were referred to us when I mean the hepatology clinic or the hepatology department, from outside the center or from different department within our hospital. And it was interesting to find that our Nafld patient or fatty liver patient in both groups, we made the diagnosis in about 78% from those who were referred from outside the center, and even 96% of those who were internally referred from other departments, for example, the endocrinology. So it shows us how really underestimated this problem yet. Another nice, interesting study, the same also in Australia, they found that those who were diagnosed with Nafld either incidental or by intent. So who was the most intentional to diagnose fatty liver? Of course, that was the gastroenterologist, but less with other general internist and family physician, and of course, the number of those who intended to diagnose Nafld for surgeons was 0. This is logic, actually. If I'm a surgeon, why should I care for Nafld actually? Those who were incidentally discovered in subspecialty, of course, it was 20% with the surgeon, that was incidentally, but 32 out also with the gastroenterologist, which is not a good to have 32 incidentally discovered with gastroenterology, because it should be the highest with intention. Anyway, all these numbers showed us that it's not really taken in consideration. Who is at risk for NASH or advanced hepatic fibrosis? I mean, who is at risk for further progression of Nafld? The risk factors are type 2 diabetes, obesity, especially visceral obesity, dyslipidemia, those with metabolic syndrome, polycystic ovary, and what is important, the relatives of Nafld patients with cirrhosis. So what is the strong clinical predictors? We have those with age above 50, type 2 diabetes, as we said, and first degree relative with Nafld cirrhosis patient, and other risk factors as the sedentary life, overweight, metabolic syndrome, and important in ethnicity here, the Asian, and as we said, it's insidious course of the disease in Asian because we usually get it in lower body mass index than we used to. So it's important, we need to identify individuals at risk and progression before the bad outcome we mentioned occur. So how? To summarize, actually most of the guidelines agreed that patients with type 2 diabetes are those who warranting workup further with the non-invasive and even invasive technique to to make the diagnosis accurately and even follow up. Do we have any current treatment? Actually, lifestyle modification and weight reduction is the main aim or the main available way to reduce fat content within the liver and prevent further progression. But we have hope to have future medication, as a lot of currently going on, especially obticolic acid, other GLP analogs, and many other medications. But what we should know, till now, no approved medication for Nafld. To summarize, Nafld is highly prevalent with variable rates of progression to NASH and advanced hepatic fibrosis. It's crucial to identify those with NASH advanced fibrosis because it can quickly progress to cirrhosis and HCC, liver transplantation, and mortality. Patients with type 2 diabetes warrant further evaluation. Other risk factors include obesity, metabolic syndrome, first-degree relatives with NASH cirrhosis. All are at risk, but still the guidelines agreed only for diabetes, but we expect that to change soon. Non-invasive tools as FibroScan may facilitate risk stratification, and no currently approved medication. So at the end, the problem is still underestimated, but we need to know that it carries a lot of side effects and bad prognosis. And thank you very much.